I'm Dylan Ratigan. I've interviewed nearly every CEO and most world leaders during the past 25 years. And now I'm bootstrapping. I'm turning my attention to the new CEOs and the irrepressible entrepreneurs leading the next generation of innovation in the world.
Published data shows within the emergency department and critical care unit, 20 to 30% of critically ill adults who undergo emergent endotracheal tube intubation experience severe, life-threatening hypoxia, with an associated mortality rate as high as 50%. Additionally, two recently published studies show that 33% of patients who undergo emergent endotracheal tube intubation within the emergency department experience hypoxia, on average, for 80 seconds. When multiple intubation attempts are required, hypoxia is experienced in 70% of patients undergoing emergent endotracheal tube intubation. Introducing the Turbo O2 cap, a revolutionary device that during difficult intubation attempts extends the safe apnea period up to 16 minutes while maintaining a greater than 97% oxygen saturation level.
Welcome back to Tasty Live. I am Dylan Ratigan. Time for some bootstrapping. My guest this week, Dr. Chris Salvino. He's the CEO at a company called SharpMed. It is a medical device incubator. And in addition to being a medical doctor, Chris is also a mechanical engineer. And what happens when you mix a medical degree with mechanical engineering is you get yourself a medical device incubator, which is what SharpMed is, from concept and development to actual prototyping and production and delivery of never before seen medical devices. This is the vision and the reality for SharpMed. It is a Republic company raising money on the Republic platform. And Chris, it's a pleasure to meet you. Thanks for the time.
Well, thanks for having me. Look forward to talking to you.
Yeah. So I can go a lot of directions here. Let's start with the medical devices themselves. What is the filter? Because there could be 1,000 medical devices, and there's an unlimited number of medical challenges, solutions, and theoretical devices. And so the first question that occurs to me in listening to the description of your organization is how you even begin to create first principles for a filter to identify what types of medical devices to target, whether it's things that do broad spectrum, cancer, heart disease, things that are big markets, if you will, or whether is it filtered for the scope of the disease that you're addressing, or the health problem you're addressing, or is it through where other people are not? Anyway, I'm sure you understand my question, but what are the first principles that you use as a filter to even begin to allocate resources for new medical devices?
Yeah, it's a great question, because if you don't do this correctly, you're going to end up creating something that's going to go nowhere. So there's really two filters that were not there 20 years ago. One filter is the device has to make sense medically. I mean, a physician or nurse or paramedic has to want to have it. They just need to have it and use it. That's the medical filter, and a lot of people have medical filter ideas. The second one that a lot of people are not aware of, though, is financial. Healthcare has changed dramatically. Physicians and nurses no longer control what devices come into a hospital. So the device has to make sense financially. The hospital system has to want it for whatever particular reason. So any kind of new device that would pass our filter system, including our own, have to have this two-step process. Does it make sense for the person writing the check to buy it? And does it make sense for the end user, the physician or nurse, to want to use it?
So I think the best next question in that context would be, what are the devices that you have greenlit, developed, and are the closest to the marketplace? Because I'm going to presume that those are the devices that you think best reflect the filter you just described.
Well, we have 5 that we've designed. One came from an outside idea. So there's 5 that are somewhere between 65 and 95% commercially ready to go to market, that we spent millions of dollars in time and effort. Then they all passed that 2-filter test. The flagship one that's closest to going to the market, that should be in the market in Q4 this year, is a device that stops people from losing their oxygen concentrations in the emergency room. And let me set the stage for that. It's called the Turbo O2 cap. So if you go to the emergency room or you're in an ambulance and your heart stops, or you're having respiratory problems, and the doctor or nurse or paramedic has to put a tube down your throat, that tube is called an endotracheal tube. That's to save your life. It's to help you ventilate, and they hook that up to a ventilator. So there's many scenarios. Again, a good one is a heart attack. Someone's having a heart attack. They're no longer breathing. They have to put this tube down your throat to breathe. The tricky part, if they cannot get that tube down your throat quickly, your oxygen levels in your bloodstream go from a high number like in the 90s to 80s to 70s to 60s, and then you're working towards brain death. And that drop in the oxygen level is called hypoxia. So going back to our scenario, it could be in an ambulance, it could be the military, it could be ICU, it could be the emergency room. Usually in a critical area, the doc or nurse tries to put this tube down, they can't do it, you get hypoxic. No one has solved that problem despite it being 2024. All we did is come up with like the post-it note of this. We created a little plastic device that'll probably cost a few dollars to make when it goes to commercialization, that sits on top of these endotracheal tubes, and we blow 100% oxygen down the tube. So as the doctor or nurse is struggling to get the tube between your vocal cords, it's blowing 100% oxygen in the back of the throat, and it's going into the lungs, and it's buying the doctor like 15 to 30 minutes of time. So this device is revolutionary. It hopefully will stop or markedly prevent this problem from taking place in any emergency room or ambulance throughout the world. So that's the first one.
So can I stop here for a second and forgive me for my potential ignorance or vulnerability to internet lore, but is not 100% oxygen highly flammable?
It would be flammable if you have a flame around it. And that's what happened to Apollo. The astronauts burned up in 100% oxygen environment under pressure. But in the scenario of in the emergency room or an ambulance, there's no flame around you. If you're in the if you're in the operating room having a procedure done, there could be a cautery device, and you wouldn't be using this device during an actual procedure. So yes, 100% oxygen can be flammable in the wrong circumstances.
But in the circumstances of a traumatic intervention in an ambulance or an ER, by definition, that circumstance does not commingle with any ignition source, basically.
Exactly. 100% agree.
Okay. What's the next thing on I love this. So keep going. What else you got?
Sure. We got, well, let's talk about, here's a fun one. Our first project, even though it's not ready to go yet, but it's getting really close. It's a device to put a tube in your chest when you need a device in your chest or a tube. If you need something in your chest to drain out pus or blood or air, that's called a chest tube. Example, older person gets a pneumonia. Fluid builds up in their chest. It has to be drained out. That's pus usually. That is drained out with the chest tube. Another scenario, someone gets a gunshot to the chest and they have blood in their chest. That has to be drained out. The common theme is these are chest tubes that are going to your chest. So up until now, what a doctor usually does is they take a scalpel or a knife and they cut a hole in your chest.
Can I just ask one question at this juncture? Which is because chest seems to be a very broad region. So when you say chest, does that mean on the outside of an individual's rib cage or penetrating through the rib cage, or it could be any of the above? It could be either one in terms of above. Yeah.
Well, you're trying to get the tube from the outside to the inside.
But is the inside on the surface of the rib cage or on the other side of the rib cage? Or it could be either one, depends.
It's on the other side. So you have your skin, your ribs, and then you go into the thoracic cavity, the chest cavity.
So a chest tube, by definition, is on the inside of the rib cage.
Correct. It goes from the outside of your skin through your chest into your chest cavity to drain stuff out.
And it could be anywhere inside the rib cage, basically.
Anywhere.
Right, up, down, whatever, wherever the issue might be. Okay, I'm sorry to interrupt, but carry on. I just want to understand what our goal here is.
So the cool thing about it is that, well, not so much cool if you're having it done to you.
Sure.
The way it's done is the doctor usually cuts a hole with a scalpel or a knife in your chest wall. Mm-hmm. And they take a clamp and they rip the muscle apart between your ribs. Mm-hmm. Then they jam this tube in there. from the outside to the inside to drain out the blood or pus. That is extremely painful because every rib has a nerve ending to it.
Mm-hmm.
On an awake patient, it's one of the worst things you could do to someone.
I would think.
Well, that technique is from the 1860s.
Mm-hmm. Mm-hmm.
So we're still using, and
No anesthesia in that process, by the way?
if you have time to numb it up with Novocaine like substance, people tend to try to numb it up. It's very difficult to numb up that area.
Mm-hmm.
And so sometimes you have to be sedated for that.
So it's sort of an opportunity for incomprehensibly excruciating pain. It sounds like you're describing there in terms of that particular intervention with limited anesthetic optionality.
Especially in an urgent situation, there's not a lot of time to numb up that area correctly. So
because if you have to do it in a traumatic intervention, there's not a lot of time to be friendly.
That's correct.
Okay, so carry on. I got you.
Well, the cool thing about this goes back to the 1860s, and this is 2024. That's over 100 years. So we came up with a device that physically sort of looks like a gun, but it's not a gun. And you squeeze a trigger, and a knife that's round comes out of the tip, cuts a millimeter cut in the skin, and locks back in. So if you fire this rapidly and you stick it against the chest wall, you can carve a hole elegantly through the chest wall in about 5 seconds.
Including the division of the muscle tissue between the ribs?
Yep, you're no longer ripping it apart.
Just a rapid pop, 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 pop. Basically, it's just a repeating contusion, but with a round blade.
Yeah, it's super cool. It's what we call minimally invasive procedure. So it's taking the 1860s and bringing it to 2024. So
what is your expectation in terms of both reduced infection and reduced trauma and theoretically reduced pain and suffering? I mean, I'm not, God knows how you would measure that, because I can't imagine you got a bunch of people signed up to try to give you some feedback, but I don't, how do you even measure the benefits?
Yeah, let's talk about that. So one of the benefits is speed and ease of use. That's been measured already in multiple different research studies in cadavers or a mannequin or a simulator. So by far, it's markedly quicker and easier. You can have a medical student use this. You can have a resident use this, an ER doctor that doesn't put a lot of these in. The question about pain is a good question that you just asked. That can only be tested in a human. So we are preparing for that to go to market in about a year. Its first generation was in the market for a couple years. We've now learned from the experience. We've created a much better product and some companion products. We created a system. So that will go to market, and for sure it's going to be faster and easier. And over time, we'll have experience with humans. And we predict it will be markedly less painful because it's minimally.
And at the very least, it seems like it's unlikely to be, for sure, faster and easier. Worst case, equally painful. I can't imagine that it would be more painful than the first procedure, which you described, which sounded quite unpleasant.
Yeah, we anticipate. We've used generation 1 that's been used in humans. The data wasn't collected. I've used it myself on patients because I'm also an end user plus the designer. And so the patients are markedly less painful with this procedure. It's going to be pretty cool.
When you just mentioned, you said you're an end user, meaning you have received a chest drainage tube using this device?
Well, I guess I'm not that end user. I'm the end user, the user. I'm as a trauma surgeon, which is why I've got scrubs on, because I did that this morning.
You're in the last mile, as they say in the telecom business, but you're not on the phone.
I'm not on the phone.
Thank God. Okay, but still fascinating. Give me one more device, and then we'll kind of circle back and talk about sort of how these things come about and where they go from here.
Let me give you one. The idea came from an outside person. Any woman that's had a baby, let's talk about that, vaginal delivery.
Okay.
Which is a big chunk of the world, if you would agree with me on that.
Uncontested, sure.
So the woman who's having a vaginal delivery, they go into the emergency room or the hospital, and to check their dilation, someone puts 2 fingers inside them and checks how dilated they are.
Manually evaluates the dilation of the, I guess it's the cervix.
And we've doctors have been making decisions for dozens of years based on that dilation, how quickly it is, how big it is. They do C-sections or they don't do them. They admit people or they don't. And they put them on drug therapy or they don't, all based on that number. And here's
based on this manual evaluation of dilation is the sort of that's the key metric for all that's the key performance indicator, if you will, for all decision making.
And that's the best they have. And last 20 years research has shown in some instances it's maybe 20% accurate. You might as well guess. Can you imagine your wife going in for a delivery?
C-section on a guess.
And here's the other tricky part. The average female has about 7 of these exams between the time they get to the hospital and their delivery. And it could be by a nurse throughout the night. Then the doctor comes in the next day, and there's different people doing it. They're taller, they're shorter, they got different fingers, different experiences. You might as well almost guess. So someone said to us, here's the problem. And we came up with a solution. We came up with a device that's really cheap to make. It sits on your second and third fingers, the doctors or nurses' fingers. Put the disposable glove over that, because whenever they do these exams, they put gloves on.
Of course.
So now they put our little measuring device underneath their glove. They put 2 fingers in, they spread their fingers, and there's a little measuring device that's disposable, and the number locks in place. So they do the exam, and let's say it's 5 centimeters.
Okay.
They spread to 5 centimeters, they close their fingers, take it out, take their glove off, says 5 centimeters, and they actually have an accurate measurement as opposed to a guess.
So basically, it's the equivalent of a ruler that goes between the pointer finger and the index finger, if I'm referring to fingers correctly. But if it goes between 2 fingers, but to come up with instead of saying, oh, that feels like 5, that feels like 4, that feels like 6, and changing people. So my version of 5 is different than your version of 5. It's absurd. And now there's a concrete measurement basically through what it would be a ruler of sorts, even though it's not a ruler, but a measuring mechanism on the glove. Am I understanding that correctly?
100% accurate. Taking that goes back to the Roman times, the 2-finger technique. That goes back thousands of years. It's been.
So where are those? So what's because I mean that one sounds like it would be easier to get into the marketplace than your chest drainage knife gun or the super oxygenator, just for different reasons and without really knowing. But it sounds like the dilation measurement glove just seems like an easier thing to take from development to the marketplace.
Yeah, it's pretty much almost commercially ready to start. We'll probably have that in the market next year. Ironically, the hard part is figuring out the 2 things that fit on your fingertips and making sure that they're soft enough for the doctor to be able to feel the cervix, but not too soft that it falls apart. So there's a few more little
materials challenge, because you want it to be non-toxic, non-allergenic, but tactile without being too fragile. Go ahead.
And well, the beauty of it sits underneath the disposable glove, so that makes it way better because it's not going to pinch. And from a toxicity point of view, it's mainly the doctor's fingers that we care about, because the patient won't actually feel the device.
Okay, so let's talk about the business for a second, because as I'm sure you know better than almost anybody else, the challenge with any medical device or biotech, any sort of medical product, whether it's a new biotech, a new drug, or a new medical device, doesn't actually matter in this case. They tend to be very capital intensive or highly capital intensive in the development phase. And also in the development phase, they tend to have absolutely no revenue and a reasonable to high probability that they will never have revenue, and potentially very high to extremely high cost of development, which is why then when you do get a drug and or a device that does work, it tends to have massive returns intended basically to reward the extreme risk and low probability of the outcomes. I guess my point is, this is a risky business and it's an expensive business. It's easy to see the sort of lucrative side of, oh, if this works, it'll be in every ambulance, or if this works, it'll be in every delivery room, or if this works, it'll be in every trauma ward. Well, sure. And then everybody, and you're like, oh, it's worth 10 billion bajillion dollars. But how much is it going to cost to find that out? And what is the probability that even if the device is perfect, and even if you get all the FDA clearances, and even if all the things are perfect, that for reasons that you can't even control, you did nothing wrong. If your device is great, the problem you solve was great, everything great, but for reasons having nothing to do with you, no, it's not happening. And so I'm curious how you are managing the investment side of this. I'm assuming you're not funding this entire thing with your own personal resources, because obviously you're raising money on Republic, and I'm assuming you've raised money from other places, probably, I'm assuming some government research money, at least I'm hoping for your sake, and then maybe some other private capital. But what is your sort of economic model for even going on this adventure?
These are great questions, because that's the reason why we're kind of in a rowboat in the ocean by ourselves. True startups really can't make it because they cannot sustain themselves through this whole entire couple-year process. And ironically, the really large companies, they used to have R&D, have laid off most of their R&D, and they mostly expand by acquisition as opposed to development. So there's very few people doing what we're doing, which in one hand is risky. At the beginning, you asked me about the filters. Those two filters are critically important. All the products we've taken on have gone through that filtering system. We've turned down our own ideas and other people's ideas if they don't meet that two-filter metric. Now, we've probably spent probably close to $8 million on the development of these 5 products. And the first one that I just mentioned, the turbo, the oxygen device, that is actually presently right now a Class 1 FDA product. We've tested this in an animal model with massive results. It's been presented at a large...
Pigs or monkeys or dogs? How far along did you go?
These were pigs, and they simulate a human's lung.
Yeah. And I have a biotech company where we work a lot with pigs on the heart stent tissue. Anyway, I have a bizarre and unusual familiarity with pig experiments. Sorry to say, don't tell anybody. But anyway, go ahead.
Well, the results, I mean, the results are going to be what's going to help drive the business there. Because when we did this, if you want 20 seconds of the model, we took pigs and they received a medication to paralyze them just like a human would in the emergency room. And the control had that endotracheal tube sitting in the back of their throat. We watched their oxygen levels go from 90s to below 70 in 45 seconds. That's on the verge of lethality. Then when we hooked up our oxygen tube to that tube, they were chemically paralyzed, not moving. Their oxygen levels went from 94, 95 to 99%, which is unreal, and stayed
incredible
there.
Validation, and it's an entirely a mechanical intervention. Is your point that the biological process is frozen, but the mechanical intervention takes what is a death spiral in a matter of minutes to actually super saturated?
So it's not like taking a car and making a car a little bit better. This is like going from a horse to a car. And as far as, there's no guarantee anything is going to go on market, but it's a Class 1 product. We are just changing our manufacturing to make it cheaper. We're focused on cost. We are trying to make this product, with the data we have research-wise, so compelling to the end user that they want to use it on everybody. We believe it'll be in the market below $10. If you can make a massive difference in someone's outcome for less than $10, that's huge. So it's not going to be a specialty product where you just use it when you think things are going to go bad. So we've had...
Yeah. So what's the purpose of the Republic raise?
It's a good question. We're going to supplement our raise because the money I've talked about before came from myself and a few other people. So we did not go out to venture capital. We control the company ourselves. we've got a really pretty important story to tell. There's 22 applied for patents and 6 that are issued, and the 5 products are fairly long in their development. So the Republic raise is just to do the final raise to get this first product through commercialization.
Meaning to get through the turbo through commercialization.
Correct.
And in theory, the turbo revenue would be used to then finance additional development of the drainage tube device and the dilation measurement device. I'm assuming, and other things, I'm sure.
Yeah, and on top of it, we have 3 NIH grants that are they're $2 million grant requests for 3 different products. So if any of those go through, they will supplement this whole process that you just mentioned. We're trying to make sure we don't have one source of revenue or one source of capital coming into the business. And if the grants go through, that's going to benefit any new investor because that's non-dilutive.
Chris, it's a pleasure. Thank you for the time, and congratulations on the success and also on your ability to overcome, I'm sure, a never-ending list of challenges. If you're interested in this one, folks, it's on the Republic platform. They are raising a couple of bucks, probably more than a couple of bucks, based on the ambitious nature of the undertaking. SharpMed is the name of the organization. It's on Republic, republic.com/SharpMed. I'm going to call you Dr. Chris, because when you give me all these details about the when you do the the chest drainage tube discussion, I need to call you doctor, or else I'm going to be afraid of you. So Dr. Salvino, it's a pleasure. I am Dylan Ratigan. You have been watching Bootstrapping, and we will be with you with more Tasty Live right after this.
Thank you.